Welcome to the acid-base lecture. I know you guys have been waiting for this, so here you go. So this lecture is going to be somewhat abbreviated compared to what we did in class because some of the slides may appear redundant. So as we discussed in class, pH is a measurement of the acids and bases in a solution. For our purposes, the acids and bases that we care about are hydrogen as the acid, bicarbonate as the base, and carbon dioxide will also function as an acid because of the result it has when it's either retained by the lungs or blown off by the lungs and its effect on the carbonic acid equation. As I mentioned in class, the human body requires a slightly alkaline pH. And what I meant by that is it sits in this range from 7.35 to 7.45, which is, according to science, slightly alkaline. So 7 being considered neutral, below 7 being in science acids, and above 7 being bases. We will use the terms acidosis and alkalosis, and our reference range will be 7.35 to 7.45. I placed these other solutions on this scale so you would have an idea of where the human body sits in relationship to commonly encountered solutions in your life. You probably have some drain cleaner somewhere around the house. I have some vinegar at home. That's why I included these, just to give you some context. We spent some time in class discussing the carbonic acid equation. And the reason I brought this up and made you aware of this is because the carbonic acid equation basically describes the way acid base is maintained in the human body. It's a shift back and forth based on metabolic needs and whatever's going on with a particular patient at that particular time that regulates whether the body is blowing off CO2, whether the body, if for some reason they're retaining CO2, if they're compensating by producing more bicarbonate and buffering that solution. I discussed 3 key components of this carbonic acid equation. The first one is circulating buffers. So the emphasis here on these 3 items are the time in which they take action and have effect in the body. Circulating buffers are anything that's in the bloodstream that can act to buffer hydrogens in the system as they rise. So, sodium bicarbonate, phosphorus, amino acids, those are substances that are circulating in the bloodstream that can immediately buffer a moderate rise in pH. But if pH continues to rise, then the body's going to have to attempts to compensate in another mechanism relatively quickly, and that's the respiratory system. The respiratory system is going to take minutes for it to have that effect. So there's an immediate action. So as things are changing, there's immediate action. Then there's action that occurs in minutes, and that's the respiratory system. So within minutes, via the respiratory system, we could either slow respirations and retain CO2 to create a more acidotic state, or we could breathe more rapidly and blow off CO2 to mitigate that acidotic state, or basically create an acidosis or an alkalosis, if we need to. So the respiratory system is able to, over a period of minutes, affect a buffering or affect a change in the pH of the human body. The kidneys, however, take time, hours, possibly even days. Their effects are longer. So we need to think circulating buffers are immediate, respiratory system is fast, and the kidneys are slow in managing and mitigating acid and base problems within the human body. On this slide, the key takeaways here are the elements that I pointed out to you on this example of a blood gas. So I called out to you on the images here a pH, a PCO2, a PO2, and the bicarbonate. The pH basically is telling you the acid, base, or normal state of the patient at the time in which you sampled these gases. That's what the pH is telling you. The PO2 is telling you about oxygen in the bloodstream. That is how much oxygen we're getting into the bloodstream of the patient. If you'll recall, during this portion of the lecture, I differentiated between oxygenation that's getting in the bloodstream and oxygenation that's getting out to the tissues. So we'll talk about later in class, we will talk about perfusion and end organ perfusion specifically, which refers to getting oxygen out to the organs at their functional location as opposed to just in the bloodstream. The PO2 reflects the oxygen in the bloodstream. The PCO2 reflects the level of carbon dioxide in the bloodstream. And this is an assessment of ventilation, how much air the patient is moving. We're going to talk extensively in the next lecture about minute volume and how the body moves air. So there will be more information to come about ventilation, but the connection you need to have in your mind is that PO2 is oxygenation and PCO2 is ventilation. Those are two key components that come out of interpreting a blood gas. Then the HCO3 is the circulating bicarbonate. So this is the bicarbonate we have in the bloodstream that is the base. It is a circulating buffer that is sitting there. This is a measurement of the circulating buffer that's sitting there waiting to or ready to buffer hydrogen should it need to be done. Now, it's important to know that that's a limited solution, and changes in that bicarbonate from baseline are changes that have happened over time, like we mentioned in the previous slide. Those are longer term changes than changes that have happened within minutes or hours. These changes in bicarbonate are minutes or hours to days. The base excess, I also mentioned base deficit. If, as on this slide, you have a negative number, negative 1.2, that's a base deficit of 1.2. If it were a positive number, if it were a positive 1.2, that would be a base excess. So it's when you're not perfectly balanced out, whether you have excess bicarbonate or need some bicarbonate. And that doesn't necessarily mean that you immediately run in there and give the patient bicarbonate. Some other items that are going to be on the blood gas that will be important to know is, of course, hematocrit and hemoglobin, because that tells us how much oxygen carrying capacity the patient has. And then oxygen saturation tells us how well we're doing with this PO2 actually getting it onto this hemoglobin. So these are important values to be aware of on a blood gas. They're not essential for interpreting whether the patient is in metabolic acidosis or alkalosis, or respiratory acidosis or alkalosis. This slide provides you the normal ranges. These are the ranges that just need to be memorized. Just commit these values to memory so that you can spontaneously know them. So as we begin to interpret blood gases, the first step is we ask, what is the pH? Is it acidotic, alkalotic, or normal? So the pH tells us if it's below 7.35, that's acidosis. If it's above 7.45, that's alkalosis. And obviously anything between those two values is considered normal. So this is a very simple determination. Is it normal? Is it alkalosis or acidosis? Very straightforward. That's our beginning. The next question we have to answer is, what's causing this problem? Another way to say that is it metabolic or respiratory? two options. So you have two options, acidosis, alkalosis. Then you have the next two options, metabolic or respiratory. So the next step we take is we look at the PCO2, the partial pressure of carbon dioxide. As PCO2 increases, that drives the pH down toward acidosis. Increased PCO2 causes acidosis. In this case, like the slide here illustrates, notice the increased arrow by the CO2 and the arrows between the water and carbonic acid, and then between carbonic acid and hydrogen, those arrows are pointing to the right. Because of that increase in CO2, the equation is going to shift that direction. If CO2 goes down, then the pH is going to move toward alkalosis. So the pH will go up. If CO2 goes down, pH goes up. Notice here, I've got a decreased arrow by CO2, and the arrows are shifting the other way. So this is then a respiratory cause of either acidosis or alkalosis. This portion here at the top is the key element to remember related to respiratory control of pH. Alkalotic pH or high pH, increased respiratory rate, decreased CO2, that produces an alkalosis. Acidic pH or low pH, decreased respiratory rate, increased CO2, and that produces acidosis. Now, it doesn't necessarily have to only be decreased respiratory rate. It can also be decreased volume, and that will make that more clear as we talk about minute volume in the next portion of class. So remember this, pH and PCO2 move in the opposite direction of each other when it is a respiratory problem. Respiratory acidosis means that pH is down, CO2 is up, respiratory opposite. If the CO2 is down, then the pH will be up, and conversely, if the pH is up, the CO2 will be down. That's a respiratory acidosis or respiratory alkalosis, whichever the condition may be. Respiratory opposite. Then the next question is, what is the bicarbonate? What role is the renal system having in this acid-base balance? So if the CO2 is normal, and we have to move to the next question, then we look at the bicarb. If bicarb is increasing, then the pH is going to go up. More bicarb, more alkalosis. Remember that bicarbonate solution I put on an earlier slide, its pH was way up high at the top end of the scale, around 8 or 9, very high pH. If bicarbonate's going up in our bloodstream, then the pH is going up. That is a metabolic alkalosis. If the bicarbonate's decreasing, then the pH is going to be driven toward acidosis. In other words, as bicarbonate goes down, acid goes down. So if it's metabolic, they're moving in the same direction. Metabolic, same. All right? And this process evolves over hours or days. So we have four basic conditions. Respiratory acidosis. In this case, we have alveolar hypoventilation. So here what we discussed is any condition in which we're not moving enough air. So we're unable to, either because of decreased respirations or decreased lung volume or both, we're unable to clear CO2 appropriately, and the CO2 goes up. This causes a respiratory acidosis. A pH of less than 7.35, that's acidosis. And the PO2 can be normal. PO2 could be abnormal. The PO2 doesn't play a role in acidosis or alkalosis. The PCO2 is elevated in respiratory acidosis. The bicarbonate can be in the normal range. Here is an example of a blood gas that has a respiratory acidosis. Notice The first question, what's the pH? It's acidotic. Then what is the next question? What's the CO2? It's 63. The pH is low, the CO2 is high. We don't have to go any further. This is respiratory acidosis. We discussed in class the main causes, or some causes, I should say, with respiratory acidosis. Any drugs, recreational prescription, that suppress the respiratory system. This can be narcotics, benzodiazepines, sedative hypnotics, anything that compromise the brain's capacity to signal respirations. Other conditions such as paralysis, as in a cervical fracture, Guillain-Barré we discussed in class. And then there are conditions which, by the nature of their condition, foster retention of CO2, such as emphysema, which is one of the COPD conditions. Obviously, a complete airway obstruction would have the same effect. The key takeaway here is the patient is not ventilating. Remember, elevated acidosis, elevated CO2, not ventilating. The treatment here is move more air, and that move more air solution depends on the problem. Obviously, if it's an airway obstruction, the treatment for that is much different than if it's drug use. The second condition, first is respiratory acidosis. The second condition, respiratory alkalosis. In this case, we're dealing with alveolar hyperventilation, either from an increased respiratory rate or increased respiratory rate and or increased respiratory volume is going to cause too much movement of air, too much removal of CO2, and cause a condition called hypocapnia, where the CO2 is less than 35. So pH is high, greater than 7.45. Alkalosis. PO2 is not going to tell us about pH. PCO2 less than 35, we don't have to go any further. We've got the explanation. This is a respiratory alkalosis, and you can see blood gases here at the side that reflect a respiratory alkalosis. Notice in this particular blood gas that the bicarbonate is 20, slightly low. That's okay. It's still the low CO2 that's causing this pH to go up. This 20 should, if it has any effect on the pH, it should make it go down. But it's not having that effect here because it's a respiratory alkalosis. So recreational drugs and prescription drugs can also produce this. This would be drugs that are stimulants, activating the system, increasing respiratory rate. Conditions such as fear, anxiety, pain, all those conditions can increase respiratory rate, cause hyperventilation. Fever and sepsis are other potential causes as well. The key here is we are over-ventilating. Notice in both respiratory conditions, the issue is ventilation. In alkalosis, we're over-ventilating. In acidosis, we're under-ventilating. Metabolic acidosis. This is number 3. So in this case, the body is producing hydrogens or retaining hydrogen ions because of some kind of biologic metabolic process other than respiratory. So this could be, there are a variety of conditions that produce this. We talked through some of these in class and their different mechanisms. We will touch on this again from time to time as we discuss gases going further in the class. Notice the connection here, pH less than 7.35. You can see that illustrated by the example blood gas on the right of the screen here. The PO2 is normal. In this case, the patient's PO2 is 81. It's fine. Again, the PO2 does not affect pH. The PCO2 here is normal, right on the button at 40, and the bicarbonate is low. Notice the bicarb on this example I'm giving you is 9.4. If the bicarb is less than 22 and the pH is low, then bicarbonate is the lack of bicarbonate is in the presence of a lot more hydrogen is what's causing this acidosis. This is a metabolic acidosis. Notice with metabolic, they're moving in the same direction. Both pH, the values we care about, pH and bicarbonate. So, pH and bicarbonate moving in the same direction. Now with metabolic acidosis, the hydrogen ions are accumulating faster than we can adapt by circulating buffers or whatever condition may be involved there. As those hydrogen ions accumulate, the body is going to try to shuffle those hydrogen ions into the cell, which will move potassium out of the cell. Potassium will exchange for hydrogen moving intracellularly, which can create a possibly slightly higher potassium in the bloodstream. And so the important thing is we don't want to be too aggressive with treating potassium issues until we correct the acidosis, unless, of course, those potassium issues are causing critical arrhythmias. Now, metabolic alkalosis is the other side of the story. So in this case, we are losing hydrogen ions relative to the bicarbonate we have in the bloodstream. The pH is elevated. The PCO2 can be normal or high. The bicarbonate is high. So if you notice in the sample we have the pH is 7.47. The PCO2 is 65. Now, that's step one and step two. Step two tells us that if the CO2 is high, the pH should be low. That's not the case here because it is a metabolic problem that's creating this alkalosis. Notice the bicarbonate level here, 46. So we have a very high bicarbonate level and a pH of 7.47. It's noteworthy that this pH is 7.47, not 7.59 or 7.6. That's because this CO2 is so high. The CO2 is helping keep this just outside the normal range. The takeaway message here is the pH and the bicarbonate are moving in the same directions. That's the takeaway. That's metabolic alkalosis. So in this case, bicarbonate ions are accumulating faster than the relative hydrogen ions. And in this case, in this process of trying to bring hydrogens back into the bloodstream, potassium's going to move now into the cell and hydrogen's going to move out. Again, we have to be careful managing potassium issues until we have our alkalosis or acidosis rectified so that we don't create problems. The qualifier to that, of course, being any critical rhythms we may have to act for now and fix later. These slides belong in another presentation. So the next point here, this was a firm takeaway. There may be mixed acid-base disturbances. This is when two different conditions are simultaneously contributing to either acidosis or alkalosis. The key here is you cannot have a mix of both acidosis and alkalosis. The mix has to do with metabolic and respiratory. You can have mixed causes, but it is always either an acidosis or an alkalosis or normal. There's not a mixed acidosis alkalosis. There is mixed metabolic respiratory. You can have a mixture, both metabolic contribution and a respiratory contribution to your acidosis, or a mixture of metabolic and respiratory contribution to your alkalosis. One or the other. You could have a mix of. All right, we've covered that. This slide I presented to you as a nomogram that you could reduce to a small handout to use as a reference when you're in the clinical environment. Obviously, you'll not be able to use this on the test. It just breaks down when your pH is less than 7.35, you're in acidosis, it's either respiratory or metabolic. And conversely, with alkalosis. The Rome method is a technique that a lot of people use as a mnemonic to help them remember. And it is simply respiratory opposite metabolic equal. By equal, we mean the arrows are moving the same direction. So with respiratory, as we've clearly discussed, pH and CO2 are moving in opposite directions. With metabolic, pH and bicarbonate are moving the same direction. This slide is just a simple, straightforward review of the differences between the major positive ions in the bloodstream and the negative ions in the bloodstream, creating the anion gap. That is, you combine chloride and bicarbonate and subtract that from sodium. Sodium's 142, chloride plus bicarbonate is 130, the anion gap is 12. And that is reflected over here on the side. You see sodium, 142. Chloride is here up to 104. Add 26 to that, that's 130. And this remainder is the anion gap. You just got to memorize the math. That's all there is to it. And as we go further and discuss different conditions, we'll point out what the anion gap is telling us. The remaining slides here are slides that we will discuss in class this week as we practice with blood gases, and you're encouraged to review them and practice them before you come to class, and they can be exercises for you. If there are questions, of course, bring those to class.